Mark. Thanks everybody for making some time today. I'm going to talk a bit about an NIH-funded research program around clinical decision support for genomic results. We started in primary care, and we're planning on going beyond. I intend to, so no conflicts, only disclaimers, I'm not a practitioner. And my goal today is to try to help everybody understand what the real challenges, more sort of short-term challenges are for genomic CDS, clinical decision support, and to try to help everybody focus on solutions and not hype. And one of those companies that's no longer in business interviewed me in 2001, and I remember sitting down in the lobby and looking down at the annual report from that company. The human genome had just been completed. There was a picture of a person's head with DNA coming out of it or something like that, and a bold proclamation that precision medicine, or I think it's personalized medicine, is here. It's the era of personalized medicine. And so that was 16 years ago, and I think that there continues to be a bit of a cycle of the sort of news and the promise being ahead of the reality. But I'm very excited that I've stuck with the biomedical domain and I'm working at CHOP especially, because I think right now we're kind of at the end of the beginning of this promise of precision personalized medicine, really zeroing in on individual patients' N of 1 explanatory factors in how kids respond to healthcare and what their individual diagnoses are. So again, buzzwords are bad. We're not going to hit a lot of those today. So before I get going, I'm going to just give a very brief, very oversimplified, again, not practitioner, lay, brief on what a genomic test result is, a clinical genomic test result. So variants are really changes in coding sequence in the genomic space, or changes in coding sequence versus some accepted reference. So variant makes sense. It's a variance from a reference. When we go through a clinical diagnostic process, we're trying to determine if some small number often of the thousands and thousands of variants that we all have that make us who we are pathogenic or might be pathogenic. And in this diagnostic process, the Division of Genomic Diagnostics relies almost entirely on literature evidence. Some of that may be rolled up into a knowledge base of some sort, but it's really about the published literature that associates some variant with pathogenic biology and patient phenotype. Now, there are also variants of uncertain significance, VUSs, that gets thrown around a lot, and I'll probably slip and just call out a VUS later, but these have no evidence in the literature, or not enough evidence in the literature to justify sort of calling this variant as the reason for a kid's disease, but they are predicted to have some pathogenic effect on biology. They're predicted, one of these coding changes is predicted to mess up an enzyme or some biological function downstream, and that prediction is sort of evidence, or it's waiting for enough evidence of association to actually be able to call that kind of variant as truly pathogenic. So in the end, a clinical genomic result is finding the genetic or genomic variation that explains a patient phenotype. So really, when we talk about decision support around this, we mean how do we communicate and help clinicians actually use this information, these genomic variants that explain patient phenotype in care. So in CDS research, I see, and this is a bit editorial, but I see three sort of large categories of work going on. There's the work around discrete actionable findings, the warfarin sensitivity that sort of creates risk or confers risk of having an adverse event to receiving the drug warfarin. It could be that there's Lynch syndrome variant on a gene. That means you definitely need to have a colonoscopy for the rest of your life. And there are studies, the EMERG Pharmacogenomic study, that are pursuing clinical decision support research in this area. There's a lot of work going on in systems. There's frankly, from my perspective, a lot of hype in this area where People are trying to figure out how to integrate genomic data into the EHR, build apps and interfaces at scale. Frankly, I think we're a ways away from that being practical or really useful in patient care. But there's a lot of work going on, and I think it's important work in that it starts to sort of force us to think about where we need to be when it comes to scalable systems. Then there are disease-specific CDS research projects, particularly in cancer, a lot in that area. And that's kind of an extension of the sort of discrete actionable category. And it's something, this kind of research is useful at CHOP. There's not as much going on in pediatrics. Actually, that's the case in all of this. And so there's a lot of opportunity to sort of help out in the community. So the need for clinical decision support at CHOP. So 2015, Pathology, the Division of Genomic Diagnostics, launched a clinical exome test that became orderable, and it became orderable to more and more divisions and clinicians over the last couple of years. There are hundreds of tests that have been ordered. There are more being ordered every month, and more being ordered every month. It's growing, the use of this test. And sort of in a little bit of counter to this work, where we have discrete actionable findings in certain disease areas, this test is being ordered for many conditions and diseases. And I just went through a digest that Dean Caraviti did of one of the research cohorts that we're studying, or one of the clinical patient cohorts that we're studying, and pulled out the indication for the test on a handful of them. And it's really all over the place. And there are groupings that we can find. But I want to reinforce that this test is being ordered for patients with, highly variable conditions. It's not just being ordered for cancer, or not just being ordered for congenital heart defect, or even just the more classic genomic syndromes, but for many other conditions. So the NIH gave us an opportunity with the announcement of the Clinical Sequencing Exploratory Research Program, I believe in 2010 or 11, to actually study practice and adoption of the exome test in real healthcare, which is, it seems to be kind of rare in that the RFA explicitly stated no discovery, only application. And we were fortunate enough, under the leadership of Ian Krantz, to receive a grant, a U-Mechanism grant to do this work. We call it the PDSeq study, and we were even more fortunate from DBHI's perspective to have a informatics project be a component of this. Pete White led that aim until he left and I took over. And this informatics project is really important because the current state of the art for return of results is a 7 or 8 page PDF that's a very dense, very informative, information-rich document that ends up in the EHR and has everything that a clinician really can know about the genomic variant and the result, but it ends up being not that accessible. So really some of the opportunity that we saw to contribute in this space was in making all of this data much more accessible to clinicians. And so we decided to take really an empirical approach. In informatics, often we want to start building things right away. We have to hold ourselves back from it, and that's really what we're doing here. So we've launched a 3-phase study, where in the first phase, we've completed a study where we established a baseline for clinical need, and I'll go through the results of that. In the second phase, we have IRB approval and are really just getting down to work to study provider workflows for real clinical cases around the return of results and how workflow and information use play out in sort of a natural environment. And in the course of that, we hope to propose a prototype that we could then trial and test the effect in practice at some future date. So this phase 1 study, we actually, as of last week, had a paper published on it. And we started with primary care because we had to start somewhere. We couldn't start everywhere. And primary care docs have to take care of kids who have every condition, any condition. And they're often involved in, and would like to be even more involved in care coordination. And they're in the nature, in the nature of their care for patients, sort of the lifespan caregiver, and often can get involved in family care, which genomic testing has implications for. So starting with primary care docs, we created a pretty straightforward study where we did a series of open-ended discovery interviews with 6 clinicians. Based on those interviews, we identified a number of themes that allowed us to construct a genetics perspective study and a mock-up of a clinical decision support tool. We then went out to the CHOPS practice-based research network, shout out to PERC, to meet with 26 primary care providers across 4 different practices. And we did a walkthrough of the tool and gave the docs a survey, and then also gave them a survey on their genetics perspectives. So results. These are the clinician roles that we talked to in our discovery interviews, and these are the main themes that we discovered. So we found that notification's a big deal. Clinicians don't know when the test has been resulted. And the report can be confusing, all kinds of information I don't understand. Care coordination, for some results, there are a whole bunch of referrals that could result, and the report result drops, and then what? So education, we have docs who really feel like they would like to know, need to know more about genomics and genomic medicine, and documentation. So this quote, it's not yet been decided who's responsible for the problem list. I've heard this similar theme many times in different talks at CHOP, but that's the same issue of who owns the problem list entry, especially, for example, an incidental finding on a genomic test result. So we then, after these interviews with these 6 docs, we went out to the practice-based research network, and we met with 26 providers that were reasonably representative of CHOP, so about the same on male-female, about the same on physician versus nurse practitioner, but different. We were oversampled in teaching practices. So that's something that you need to take as a caveat with what I'll discuss. When it comes to the genetics perspectives, docs felt generally confident that they understood basic genetic principles. They thought that they should be involved in this care, and but they felt underprepared. I mean, these 2 are a bit in opposition, but they felt underprepared to engage with patients on genetic conditions that really had some consequence. And they really were at a bit of a loss of how to just sort of weave all of this into their practice, these primary care providers. So after we gathered up genetics perspectives from the docs, we walked them through a mock-up of a clinical decision support tool. And this is sort of a reality-based case study. There was a real result in our PDC research study where a patient had an RYR1 variant, which conferred risk of an adverse event to a risk of an adverse reaction to anesthetics. And so we assembled sort of a functional view of a result that would allow docs to sort of receive the education that could be helpful to them, deliver education to families that could be helpful to the families, do some documentation, including adding some allergies and alerts in this particular case. And this was framed in a larger context where there was inbox notification of the result, which isn't a given. You would think it would be, but it's not. And also access to the actual underlying test report. So generally speaking, the clinicians thought that this was useful. Everybody liked it a lot against some of the sort of functional areas that we thought addressed the needs that our discovery interviews uncovered, and that it would be useful in their work, and enhance workflow. Productivity, some questions there, and we didn't tease apart in our survey sort of any reasons that would explain that. So there's some potential follow-up work to be done. So thought the tool would be useful. Thought the tool had important functionality. Thought the tool would be useful. Again, this was just a mock-up. So from this, we've concluded that primary care providers are ready for some help in this area. They think that they have a role to play, but they're a bit unprepared, and that in the end we have, with this mock-up, really kind of an evidence-based model for how we could provide decision support. So that was phase one. Paper's out. I'm happy to send a reference along if anybody would like to read more. So phase two, this is what we're doing right now. We have an IRB protocol that's been approved, and we're really trying to find real gaps in how this information is used in practice. And so we have a study, we're kind of right here on this, at this step. We have a study where we've queried EPIC and found 59 patients who have had exome sequencing and see a CHOP primary care doc. And we also, it's very important for the sort of primary care and beyond that these patients are also seeing CHOP specialists, and they all are. We have, based on a case review with Roberts IMGC, Individualized Medical Genomic Center, we have identified a cohort of about 20 patients who have a medically actionable result and or a variant of uncertain significance that requires or prompts some follow-up. It could be to collect additional family history, it could be to rephenotype at some later date, but a VUS where there's probably something there and we need to pay attention. So from this point, what we're going to do is develop an interview guide that'll allow us to go to both primary care docs and specialty care docs who care for those actual patients and do a really deep descriptive interview with them of how they have received these results, what they've done in response, how they've documented or not based on these results, follow-up care, referrals, additional procedures or tests that have been ordered, to really just understand, at least for this sample, what's going on after the test. And based on what we hear there, we are pretty sure we're going to find some gaps that need to be addressed, and we're going to prototype a clinical decision support tool, actually using a few different technologies: pure EPIC customization, some standards that are called Smart on Fire, and Best Practice Alert, which is kind of the stock EPIC coding that tool that you can use for CDS. So those prototypes, we're going to then go back to the docs and do a bit of a usability test to say, hey, we identified these gaps. Here's how we propose to close them. What do you think? So that's ongoing. So phase three. If we can get through phase two, when we get through phase two, it's going to be time to actually build and deploy and test. And so the intent is to pick one of the prototype implementations. Most likely it'll be the standards-based one. It could be the pure EPIC customization. It probably won't be the best practice alert. But actually identify and baseline some measures of the current state. And this is really challenging. And at a CSER consortium meeting 2 weeks ago, I saw a talk from a gentleman from the National Quality Forum who was there to say, hey, you guys need some measures. And NQF establishes and validates measures for systems and processes and outcomes and patient safety and publishes them. And there may be an opportunity to use existing measures around care coordination. There may be an opportunity to actually develop and validate some new measures around figuring out what the impact and effect of CDS for genomic decision support is. CDS for genomic results is. And then we'll build a production tool, we'll put it into EPIC, and we'll do a trial with a limited patient cohort. So this is Sunday. I want to quickly call out some other work that's going on at CHOP. That is the EMERG Pharmacogenomic study, which launched in 2014. Hakan Hakan Arslan is the PI for CHOP as a site. And this study is exploring how to how to actually provide decision support for targeted pharmacogenomic risk alleles, risk variants, in a pilot group of patients. And this is, again, that category of discrete actionable findings, of which there are some, but not a giant laundry list. And this has pretty serious implications for patient safety. If we're able to actually sort of quantify or at least flag a patient as being at risk of an adverse reaction to a drug based on their genomics, then we have the opportunity to change how we do medication reconciliation, or to change how we alert on allergies, or otherwise avoid harm in this area. There's also potentially an upside if a patient would respond to one drug versus another. You could think about a lot of different scenarios for how this could play out. So this EMERG work is ongoing. I am going to call out, based on all of this work, and I'm not showing you any specific results or evidence, but I'm going to call out what we all see as an enormous gap to scaling up any of this. And I've spoken in the abstract about sort of the discovery that we need to do to set the stage to actually do decision support. Let's say we're able to build a system and trial it in a cohort of 25 children. Behind the scenes, we're going to have to curate a knowledge base that maps gene variants to clinical guidelines and educational materials, because that's really where a lot of the decision support is going to be. We're going to have recommendations and rules for gene variants that we can provide to clinicians to act on. We're going to have to take into account the fact that the literature changes our ability to associate a variant of uncertain significance with a phenotype and turn that VUS into a pathogenic variant, or call it as a pathogenic variant. That changes over time. And so there's a big question about how to reanalyze these data and reinterpret these data in the context of new information. A child develops disease where they hadn't had it before, new family history comes to light, and that reanalysis sort of factors into this knowledge management function that needs to be in place. This could take the form of an expert curated knowledge base, a database. Unfortunately, outside of specific disease areas, cancer being one of them, there are not a lot of third-party options. So is this something we want to build? Do we want to become the curators of such a knowledge management database system for CHOP, for others? It's a pretty big question. And I can't sort of overstate, how important this is to doing decision support beyond just a pilot research study. So, given that, my final thoughts are that this is here. This is happening right now. So across the care network, there are patients who've had exome tests who are being seen at well-child visits. Central Bucks 4, Flowertown 5, Indian Valley 4, Terrebonne 7, just up the road, Newtown, South Philly, and Westchester. This is a handful right now, but it just grows over time. These kids come back and see their primary care docs every year, hopefully, at their well visits. They have brothers and sisters, they have siblings, they have aunts and uncles. So this is happening right now. That's why I really think that we're at the end of the beginning of this, of precision medicine, personalized medicine. So we have to decide what we aspire to, given this reality. What do we want to be? What do we want to do when it comes to the dissemination and use of genomic test results beyond the sort of immediate indication for test, or even for the indication for test? How do we want this information to be adopted and used? And to me, this really highlights how maybe a cardiologist ordered the exome test. There was a medical interpretation performed by the Individualized Medical Genetics Center, the Roberts IMGC, but there's a primary care doc out there who is well on the other side of all of that and needs some help. We have anecdote after anecdote of a parent actually bringing up that test result with the primary care doc finding out about the test from mom and dad. So again, what do we aspire to? How do we integrate care? That's maybe an answer to what do we aspire to. How do we take how do we take new medical information that has potentially broad implications for a patient and their family and provide integrated care to them? That's what I would expect as a patient. And again, one other sort of last point, how does research fit into this? So there are 3 big shiny buildings full of people who are trying to figure out how genomic variation, biological variation can explain phenotype. And so when we have a variant of uncertain significance, what do we do with it? Do we just wait around until another 2 or 3 papers are published by somebody else to explain the relationship between that variant and phenotype? Do we take on that work ourselves? When there are new modalities, RNA-seq, that have potential clinical diagnostic utility, how do we go from research to the clinic? And it was very interesting and an incredibly sort of humbling and valuable experience for me to be working in genomics in 2001, come to CHOP in the pre-genomic medicine era and see the exome go from a research tool to a clinical diagnostic. That arc is going to repeat, and it's already starting across the courtyard. So again, I'd love to talk more with anybody about these questions and others that you have, because I really think that this isn't an exhaustive list, but I think we're at the starting line in a lot of ways, and we need to think pretty critically and act very deliberately at this point, or it's just going to sort of we're going to keep flailing. And I think that all of these patients and families expect more. So I need to acknowledge the NIH funding that supported all of this. So I especially need to acknowledge Dean Caraviti, sitting down there reading his email. Oh, he's working on the IRB. Tireless. I really need to acknowledge Dean, who's been very inspired and has put in long hours and brought a lot of creative thought to this work. Bob Grunmeyer, Jarrett Thayer, Barbara Bernhardt, Edward Krause, Lydia and Emma from the IMGC, Ian and Nancy, and the Pediatric Research Consortium for helping all of this to come to pass. So with that, I'll take questions.